program. And we are very pleased to welcome you to the first program today, Imaging in Uveitis. As you can see, the program have an outstanding list of speakers with whom you will be seeing and listening to very shortly. In this particular program, we focus on the advances in the diagnosis and monitoring of disease using various type of imaging in uveitis. Certainly, this program has been the major work of our colleague led by Dr. Anindra Agarwal from the UAE, who has been spending a countless number of time with his colleague, Dr. Wataru Matsumiya from Japan, along with Dr. Emont from Thailand, who have been working very hard to this. And today we'll be very pleased to see a number of colleagues with that. Next slide, please. Our faculty are listed here, and you can tell they are come from different countries around the world. Because of that, we are also very, very pleased to let everyone know that as of today, we have had more than 500 registrants for this program. This 500, more than 500 registrants representing more than 65 countries have registered for this program, and therefore many of our colleagues are listening at this moment. And once again, we welcome to all of you. Next slide, please. Certainly, a program of this magnitude would not have been possible without the support of our colleagues. And at this time, we would like to take this opportunity to thank our colleague at Roche and at Centon for providing the International Ocular Inflammation Society with unrestricted educational funds to put this program together. As a full disclosure, neither Roche nor Centon have any role in the planning of this program, all of which are done by our member with that. However, we appreciate their support to allow us to sponsor and to host this teach educational program. And with that, I will turn the program now over to Dr. Aniruddha and Dr. Arnis for leading the program. Aniruddha, Iris, please go ahead.
Thank you, Professor. So I'm Ioannis Papasavas, and alongside Aniruddha, we're going to present to you the program. So I'm happy to call on stage Alessandro Marchese for the first presentation of OCT biomarkers of infectious posterior uveitis. Alessandro, up to you.
Thank you. Hello, everyone. I'm going to have a presentation on OCT biomarkers of infectious posterior uveitis, and it's an honor for me to be up here. And this is going to be a case-based presentation. Let's start with the first case. This is the case of a female, 68-year-old, who presented to us for bilateral visual loss for 2 days. She has history of hospitalization 1 month before for a spondylodiscitis with pulmonary nodules of unknown origin. And she had negative cultures, including a bone biopsy and lung biopsy, but a positive beta-D-glucan. When she presented to us, the vision was very poor, with right eye counting fingers and left eye 28-100. She had also anterior signs of inflammation with 2+ cells. And when we look at the back of her eye, you can see there is significant vitreitis with the whitish vitreal infiltrates. These infiltrates are better appreciated in the left eye. And here you can see these 2 infiltrates. And there is also a large area of what appears to be a deep chorioretinal lesion. In these cases, you always want to try to get to have an OCT through the lesion. But as you can see, the media were so aged that the information from the OCT were not very good at this stage. So in this moment, we decided to perform a fluorescein angiography, and you're going to hear after the usefulness of this exam, especially when there is significant age. You can have information like a hot disc here, and you can see this area of non-perfusion in the upper temporal area of the left eye. So based on the findings, we decided to perform a diagnostic and therapeutic vitrectomy and start the patient for on antifungal medication. And this is the view 1 day post-operative. You can see it's much better now. You can appreciate the yellow chorioretinal lesion after temporal. And here you have the one of the most important messages from my talk. Then whenever you suspect an infectious uveitis and you want to have information from the OCT, you should have the scan through the chorioretinal lesion because looking at the macula is completely normal and you're not going to have many clues. Digging deeper on the chorioretinal lesion, we can see it has a component of hyperreflectivity where you cannot tell the retinal layers apart anymore. And there is also a large vitreous opacity there. And if we compare this finding to what we can find on the literature, we can see that the vitreal lesion, it really looks like a rain cloud sign, where you can see these retinal aggregates obscuring the underlying retina because of a shadowing effect. And if we look back to the chorioretinal lesion, you have a complete opacification that is usually suggestive of retinitis. In this case, the choroid also seem involved, and it's very similar to what has been described in fungal infections like Candida. When you have a retinitis on OCT, you usually have a full thickness hyperreflectivity with opacification of the layers, and you have disruption of the retina. But there are also other information that can be useful if you want to narrow down your differential. For example, in toxo, usually under the area of the retinitis, you cannot see the choroidal architecture anymore because of significant disruption. While in viral cases, usually the choroidal architecture under the retinitis area, it can be still seen. Sometimes when you have this large lesion, you always want to have in back of your mind also that lymphomatous patient may have similar retinitis-like lesions. But back to our case, the vitreous biopsy and the aspirates, they turn out to be negative, including PCR, cultures, and smear for fungi, bacteria, and malignant cells. But we still had the other eye. In the middle Y, the lesions there was growing, similarly to the fellow eye. So we decided again to take the patient to the OR, and we took a chunk of the lesion and we sent it for PAT analysis. And as you can see here on the PAT slide, we have a very large colony of what turned out to be a mold, specifically Shadosporium apiospermium, which is a very aggressive infection that usually affect immunocompromised patient or patient hospitalized. Now I'm going to go to the second case of my presentation. This is a 22-year-old male who presented for left eye visual loss for a week. He has a past medical history that was remarkable, and the vision was preserved in the right eye with 20/20 and was 20/200 in the left eye, where you can see significant retinal vascular tortuosity and optic disc edema. And when we look at the OCT, we have a significant optic disc swelling, but also we have subfoveal serous retinal detachment and some intraretinal hyperreflective foci that are sometimes seen also in patients with neuroretinitis. So is this like a retinal vein occlusion or there is something else going on? If we take a very close look at the OCT, at first we cannot see much in the choroid, but if we really try to look very carefully at the scan, you can see there is an area where the inner choroid, it looks featureless. And under that area, there is a choroidal hypertransmission. And when you see something like this and you have an inflamed eye, you should always suspect there might be choroiditis there. And the exam that can confirm that is an angiography. On FA, it's very difficult to see choroiditis unless in the early frames. But if you do ICGA, you can see these hypofluorescent areas scattered throughout the retina that are foci of choroiditis lesions. And if you go in the late phase of the ICG exam, you can see some of the choroidal lesion, they kind of disappear because they are not full thickness. And so the dye surrounding the choroiditis area blur them. When you see choroiditis in inflamed eye, you always want to rule out TB, and the patient turned out to be quantiferon TB positive. And tubercular choroiditis can present similarly with a featureless and thickened choroid corresponding to the active choroiditis area. And on histology, of course, not of this eye, but of previous eyes, you can see an areas of necrosis. The patient was treated with the ATT, anti-tubercular TB treatment, along with corticosteroids, and you can see that responding very well to the treatment. So to sum up my presentation, when you use OCT and suspect infectious uveitis, you should always obtain a scan of the lesions itself, not just of the macula, because this is the most helpful way. You should be able to recognize signs of infections on OCT, like retinitis and choroiditis, because OCT can help you to narrow down your differential diagnosis and execute appropriate labs to secure your diagnosis. Thank you.
Thank you, Alessandro. Thank you very much for your talk. Just to summarize a little bit the talk of Alessandro, as he said, it's very important to pass through the lesion if you see a lesion in the back of the eye, because sometimes macula could be normal. So this information can give you more details about the lesion, passing through the lesion. And of course, as he said, it's not only the retina, it's also the choroid. So sometimes EDI OCT can help to see the structures of choroid and see if there is any disturbance, any alteration. So don't forget to do an OCT, see through the lesion to see which layer of the retina is affected, if the choroid is affected. And as Alessandro said, recognize these signs and always think of an infectious disease. I don't know if someone in the panel has anything to add or there is any question from the chat. I think we're fine. So Aniroda, up to you.
Thank you, Alessandro and IOIS. It's a pleasure for me to introduce my friend and colleague, Professor Marian Monk from Switzerland. She is an excellent researcher in retina and uveitis, and she will be presenting a topic which is slightly offbeat, which is the future of retinal imaging in uveitis, and we'll discuss the presentation after. Over to you, Marian. You can share your screen.
Thank you so much, and thank you very much for the kind invitation. I'm really looking forward to presenting here and having this great setup and meeting today. Let me share my screen. All right. All right, so today you will mainly hear what you can already do with imaging in uveitis, and my topic will a little bit be to predict what we will use in the future in order to image uveitis. These financial disclosures, none of them are relevant for this talk. Of course, as we know, predictions are difficult, especially when they concern the future. And so as all of us are doing nowadays, I ask different LLMs how they will see the future of retinal imaging of uveitis. Actually, I was quite disappointed by what came out from the 3 different LLMs here. So from my perspective, these kind of predictions are not very creative on the one hand, and on the second hand, what I saw here that still LLMs see the medical future in the hands of men and not divided between men and women. So I definitely thought I can do better. But what I agree with is that imaging will become very intertwined with AI in the future. So let's have a look what is possible right now, and then let's have a look at a glimpse how it could move forward in the future. So first of all, nowadays, at least in the scientific settings, we are able and it's possible to really quantify vitritis. So we have nowadays OCT-based quantifications of vitreous flare as well as vitreous cells. The way I will see the future here is that we will really have automated standardized quantification of these vitreous flare and vitreous cells, really valuable and usable in the clinic and also for clinical trials. This can be then connected with ultra high resolution OCT, which will not only allow to quantify the individual cells, but also differentiate the cells, which will then also allow us to differentiate the underlying causes of the vitreous cells and vitreous flare in the near future. Of course, cutting edge now is also, we can at least in a scientific setting know and predict the perfusion density of the choroid. And we have seen so far that the perfusion density in the choroid is in active posterior uveitis significantly higher than in inactive disease. Again, how I can envision the future is that it will allow us to predict disease activity really based on the OCTA images in the near future in panuveitis and posterior uveitis. What can we do now? Of course, we can use quantification, AI-based quantification, for example, to predict secondary CNV development in multifocal choroiditis and PIC. Again, so far only in scientific settings, but in the future we already see it's happening, and we will probably be able to predict flares and also secondary CNV development in different posterior uveitis diseases. Also, one thing I really strongly believe is that no dye angiography will become practical. What can we do right now? So cutting edge now is that we have OCTA images and devices or models on the market which allow a field of view of OCTA images of one shot, capturing a field of view of 130 degrees. And if you montage the different images, you will be able to get an OCTA on FastMap up to 200 degree field of view. And if you compare this, this actually translates completely into wide field color funders or wide field FA images nowadays. At least from the scientific setting, we are also able to do cross-model image translation and also inferred and synthetic FA and ICG. So what can we do right now? Like I've already mentioned, we nowadays, at least again in the scientific setting, have cycloguns and conditional guns which allow cross-model image translation and image-to-image translation. This, for example, is some ongoing work from our group where we translate OCTA images into inferred FAs. Another work here from the Murata group, which actually shows that you can also do this with OCTAs, where you use OCTAs in order to generate inferred fluorescein angiographies. What will the future bring? Probably synthetic FAs. So probably what we will be able to do, that we have OCTA, color funder images and autofluorescent images taken, and they can then be transferred via cycloguns into synthetic FAs we can use in a clinic. Of course, this will help us in a lot of cases, but if we see cases where we see that the inferred FA is of low probability, in these cases, we will still need real FAs and ICGs in order to understand treatment hinges or find leaking details. Another thing I can see coming in the future are really dynamic OCT and OCTA images, allowing an AI leakage interference. What I mean by that is, for example, OCTA images becomes faster and faster, and so we will kind of perform and acquire multiple OCTA volumes with variable interscan times, and this information will then be extracted from the algorithms in order for example, OCTA signal heterogeneity between the different variable interscan times. And this kind of feature extraction will then allow a kind of a leakage probability map, as you can see here, and also vasculitis activity scores. And then here, again, fluorescein angiography and ICG will be only necessary if our model flags high uncertainty for in terms of the probability, or if you have a very special case and you're really not sure whether what you see is leakage or vasculitis. Another current cutting edge is next generation autofluorescent images. Nowadays, of course, we have the blue peak as well as the near autofluorescent images, especially useful in placoid diseases in uveitis. But for currently, we also have color autofluorescent images and also quantitative autofluorescent images, as well as FLIO, which actually assesses the fluorescence lifetime images and emission duration and not only the intensity of the signal. And also, and already nowadays, this allows detections of specific patterns. A very special model of autofluorescent images is the metabolic images, which is a retinal flavoprotein fluorescence, which allows actually to act as a mitochondrial dysfunction biomarker. This is already on the market, it's already used, and it's currently also validated and evaluated for uveitis. What I can see in the future is kind of metabolic activity maps alongside OCT, where we get using these metabolic imaging and oxidative stress and mitochondrial dysfunctional pattern map, which allows us actually to predict flare before we even see structural changes such as leakage or edema. In this similar way, we also nowadays have hyperspectral imaging or molecular contrast imaging. Actually, it's also reflectance imaging. You're also well aware of that because we use it in these kind of standard pseudo-color images, but usually we use only the red, green, and blue channel. But this spectral and hyperspectral imaging actually uses a wide range of wavelengths and therefore investigates molecular level insights of different diseases. What I see in the future that we can, using this hyperspectral imaging, get a spectral inflammation fingerprint that, for example, differentiates active versus inactive versus non-perfusion or inflammation in these patients. So in the future, we will definitely be partially able to replace dye. We will have metabolic imaging and hyperspectral molecular imaging for our patients, and we will also use AI as an interface to combine all the information we have nowadays. Thank you very much.
Thank you, Marian. That's very exhaustive, and I think you've covered a lot of entities. And for sure, you also mentioned the use of AI in almost all imaging modalities that we have in the clinic. In terms of practicality in the clinic, can I ask you, which imaging modalities do you see would be probably considered to be the basic minimum that should, be done for patients with, let's say, a posterior uveitis?
I think definitely OCT, but alongside autofluorescent images. I think these are the two modalities every clinic in uveitis will need in the future and as well now. Yeah.
When you are analyzing patients in your clinic currently, can I ask you if do you use any AI imaging analysis or on your daily routine patients? What is one thing that you have started applying routinely in your clinical practice?
So I try to be early adopter. So I really use a cloud-based image tool which allows me the automatic quantification of lesions as well as of fluid in patients. So I use this for medical retina as well as uveitis patients. But I really have to admit, for now, it's not rather a time saver. It actually adds up time. But I think you have to start using these tools in order to really see what you can get out of it. It's the same with OCTA. If you don't use it, you won't see the benefits you get. You would just think, okay, I don't need this tool. I mean, I lived with OCT alone the whole time. So I think you really have to start using it in order to see the benefits. And that's what I'm trying right now. Yeah. I don't know how you see it or how you do it.
I think that's a very important point. I think it's a very important point, and you couldn't have said it better. If you don't use it, you will not be able to understand the benefits. And of late in the clinics, it sometimes becomes very busy, and we may not apply OCT angiography, or even we may not even perform OCT angiography, and we may just be satisfied with an OCT. But the moment you perform these imaging and you try to analyze them, maybe after the clinic, maybe not during that time, and you have these images for your analysis, it definitely gives you more added value and information that can be used in the patient management. So we have moved on from just screening patients, like let's say diabetic retinopathy screening or screening for uveitis or vasculitis, to actually therapeutic decision making when it comes to analysis of the OCT, thickening of the choroid, the amount of vascularity that you see in lesions like inflammatory CNV or even peripheral retinal vasculitis. So I think by adopting one tool at a time, we can sort of advance in this field and be there, for the analysis. The future is here. The artificial intelligence is here, and I think this is definitely a part of a routine practice that we should incorporate.
I
Any
just want to add
questions?
you because you said
IONS,
the
would you like
future.
to?
I
Yes.
just wanted to say, because you said the future is here, totally, I totally agree with that sentence. It's just the future is here. We just need to implement it. That I think that's the thing, and that's currently the challenge. Yeah.
Absolutely. So I think you've covered almost every imaging modality. Dr. Wen, do you have a question or comment?
Sure. I have a question for Marion here. So certainly all of us are wanting to avoid invasive procedure like fluorescein in order to do that. And certainly a number of manuscript, number of discussions we've been on. I want to find out from you, have you been able to identify a modality that can really replace FA in terms of showing the degree of leakage, let's say of vessel and things of this aspect? Because we definitely recognize and do not necessarily want to use FA, but I'm still struggling to see how we can assess at the moment the type of leakage, because OCTA has not been able to demonstrate just far yet.
I totally agree with you, Kwan. And actually, I really have to say, I do a lot of FAs and ICG in my clinic. So there is actually no day where I haven't done like several FAs and ICGs in my clinic. And everyone hates me for that, especially the staff. So I agree. So far, there is nothing which can really reliably replace it. What I use is OCT thickness maps. Usually, what I do usually is in patients which have a vasculitis, but of course only in the larger vessels. So if you have like small vessel vasculitis or peripheral vascular leakage, it's not useful. But if you have like, for example, a periphlebitis, I use the OCT thickness maps. I do that alongside with the FA. And if I see this perivascular thickening, I really use these thickness maps in order to follow the patients and to see whether they respond to the treatment. That is what I'm doing, but it's definitely not replacing. And again, if I use it over time and then I see an increase again, then I repeat the FA. So it's just for me a little bit of a monitoring tool, but it's definitely not a replacement.
Thank you, Marion.
Marion, before we let you go, there is one question from the chat. This is from Brazil, Dr. Pereira, who's asking you, do you know if there is any AI application in ocular ultrasound, for example, in vitritis quantification or any other pathologies?
That's a very, very good question. I am not aware of that. Unfortunately, not. I think it has to do with our age, because I mean, all the ultrasound experts, they use ultrasound and everything, are rather older, and they're more going towards, retirement. They're not so much not so much active anymore in research. And we nowadays, we are very often, I mean, we're, even if you evaluate the PVD, you do an OCT, you don't do an ultrasound, things like this. So I think we don't use it so much in our daily clinic, and this is why we don't feel comfortable with it, and this is why it hasn't been implemented. But I think it's a very, very good point, and I think you could get a lot of information out of it, maybe even more than with an OCT.
Thank
Back
you.
to you,
Thank you,
IONS.
Professor Monk. So it's a great pleasure to call on stage William Tucker from Moorfields, London, to present the FFA interpretation in common posterior uveitic entities, and Professor Neri from I don't remember where are you, Neri, at the moment. You are changing so much. So Professor Neri actually will discuss the William Tucker talk. Thank you, both of you.
Thank you, Yanis. Thank you to IOIS for inviting me to speak. And it's a great talk to follow Marion there, as she both hit down on FFA and also built it back up again at the end. So I'm very pleased to present this FFA in posterior uveitis talk. And so we're going to briefly talk about the relevance still of fluorescent angiography. Where does it fit into our assessment? And then really focus on the signs to look for in posterior uveitis. I'm going to assume some knowledge of the history of fluorescein, something about the phases of angiograms, early to late, and that our choriocapillaries have fenestrated, leaky vessels, and our retinas have tight junctions, are not normally leaky. So, as we've just discussed, where does fluorescein still fit into this world of modern multimodal imaging? And we've just also presaged my later argument that nothing really shows leakage at the moment from inflamed vessels like the fluorescent angiogram. And it's this repeatable, comparable imaging that is used for the diagnosis and the follow-up. So we also talked briefly about what would be considered the minimum imaging. And so there's been recent publications from the MUV task force around this, and FFA was only really considered part of the MIS, the minimum imaging set for AMPI and birdshot. But this is important to remember, this is the minimum imaging set. And if you are lucky enough to have easy access to fluorescent angiography, then it's useful to do it on all your patients, because we can't really find out what's going on with our patients unless we do and future research as well by doing all this imaging as well. So if you have access to it, as we do where I work, then we like to use it. Professor Herbert produced this wonderful paper 17 years ago now, which we still rely on, and I'm just summarized some of it here. So broadly speaking, with hypofluorescence, we look for transmission defects and blocking, hemorrhages, pigment. We look for filling defects from ischemia of the arteries or the choriocapillaries in the first 60 seconds. We look for hyperfluorescence from leakage from the vessels, from the disc, giving you a hot disc, and through pooling and staining. And then we look for the window defects with atrophy and abnormal vessels as well. So we're going to literally now go through some posterior uveitis entities. I'm mainly going to be using Optos FFA. We're lucky to have that. It's essential for our care that we give the ultra wide field FFAs. And I'm going to assume we all understand the role of ICG angiography. We're going to touch on that, I think, later with the stromal choroiditis talk. But just to remind you, this is a lady with the right eye diagnosed as anchor-associated retinal vasculitis because she had a positive anchor. But the unit she went to didn't have an ICG. And when she came to see us in Moorfields, we did an ICG and discovered actually she had birdshot chorioretinitis. So diagnostic signs mainly going to be shown. These are not mystery cases. I'm going to be focusing on the kind of classic signs, and unfortunately no real time for an in-depth discussion of the disease pathophysiology. So we'll start off with AMPI, and having said that, I'm not going to talk about pathophysiology or show you lots of other imaging types. This is one of my favorite slides I've ever produced, showing you here at the bottom the classic block early on in the fluorescein from the choriocapillary ischemia, and then the late staining on the FFA. But of course, we now know it's choriocapillary changes because of these kind of images, which show us that there is a lesion here highlighted with the red arrow on the early fluorescein on the ICG pictures, which then disappears when we focus on the more retinal images of the photo and the FAF later on. So as we start to run through our entities now, so we're going to go to MUDES. MUDES has this classic wreath-like lesion on a fluorescent angiography. What that basically means is hypofluorescent in the center of one of these dots, and then this little hyperfluorescent wreath around the center, and characteristic changes on the autofluorescence and the ICG as well. And you can follow this up, obviously, with repeated angiograms if necessary. With a serpiginous chorioretinitis, the classic findings are of a hyperfluorescent ring around the edge of the more chronic lesions. But this case I've chosen here because we see this halo of increased fluorescence around these, the top and the bottom of this case here. And when we do the OCT, we can see this is active areas of chorioretinitis. And you can also see this on the ICG, where these lesions around the disc are more chronic, and these lesions here look more active and fluffy. For a TB-related pseudoserpiginous or amphiginous chorioretinitis, it can look quite confusing at first. Some of these lesions are older, some of them are newer. Which are the ones we need to be, which ones are we actually trying to treat? So we do fluorescein at this point. We can see that some of these lesions around the disc, again, are more heterogeneous, look older, and that's backed up by the ICG findings as well. Whereas some of our darker lesions here are the newer active areas of chorioretinitis. And then when we follow the patient up with a post-steroid, post-TB RX FFA, we see now that all the lesions now have that chronic heterogeneous pattern with some pigment blocking, and the ICG itself looks much better. For the VKH, we're looking for that classic starry sky picture early on. So this is pinpoint hyperfluorescent leak, which then leaks into large pools of subretinal fluid, as we can see here on the OCT. We can see in this very late FFA done on the Optos for this same patient, 30 minutes later, these pools of fluid have all filled up, which is a way to distinguish from CSCR. And the actual retinal vessels themselves are not really involved in the inflammation. So a key differentiator from some of the later conditions we'll see. And the disc obviously is very, very hot. So what else can it show us? It shows some of the complications of uveitis. We're familiar, obviously, with an OCT showing us beautiful cystic macular edema and the FFA findings. But of course, OCTs can fail to show cystic changes, can just show diffuse thickening. But when you do the FFA, you see angiographic macular edema. As we transition to a world where we have more treatments available for macular edema, we may be able to do angiograms or the equivalent of them, as Marion has suggested, to look for angiographic macular edema as well. In this Burchot patient, we have multiple Burchot lesions, but we also have a lesion which is not like a Burchot lesion. And this is, in fact, a choroidal neovascular membrane that we've highlighted by doing the fluorescein. So the lesion is here, and as we see, it increases in its fluorescein staining and leak over time. And then when we do an OCT through it, we show the trident inflammatory CMVM signs. If I ask you to search for long enough, then of course you'll be able to find the new vessels here in this ischemic vasculitis. But if you do the fluorescein, they're very clearly highlighted for you, and also the area of ischemia that you will need to consider lasering as well. In this case of viral retinitis, acute retinal necrosis, these are viral retinitis tends to be a clinical diagnosis and or then from sampling of the eye and the PCR. But we often do the angiograms at Moorfields when we see cases where the vision doesn't fit with the necrosis that we're seeing. And in this case, the patient has had a branch retinal artery occlusion as well, which has then led to severe vision loss, and the angiogram has hopefully delineated that. Similarly, as many of you have seen my colleague Ilaria Testi speaking about our cytomegaloid retinitis patients, where we've increasingly shown lots of ischemia in these patients. This is a slightly less severe case, and then this is one of our more severe cases. And so where we've been doing the angiograms in these cases, it's been helping with prognosis for the patient as well, because unfortunately, clearly this patient's prognosis is worse despite every aspect of treatment that we can give them. With a Susac syndrome, most of these patients, you may well be referred them from a neurologist with a suspicion already of Susac's, or you may find them in a patient with a branch retinal artery occlusion, and then investigate them further. But with a Susac syndrome, these changes can be subtle. There is a change on this color picture here, but luckily I've got the FFA to highlight it for you here. And so this focal periarteritis, which even when I zoom in and increase the contrast, is difficult to see on the color. And this can be followed up over time, and new areas may appear over time as well. A much more obvious systemic vasculitis can give you this wide-ranging ischemic areas with the focal periarteritis as well. And then in the toxoplasma case, we get blocking and then staining late on. But I'm showing you this case to show you the Chiariolasis plaques. As you can see, they're very prevalent around this vessel here, but they don't result in vascular leakage. They can increase in fluorescence over time and on the ICG as well. They are not the same as an arteritis as you would see in a viral retinitis. This is a phlebitis with the skip lesions, particularly severe skip lesions of sarcoidosis, and it's essentially the candle wax drippings as well. And we can see this is matched with the ICG as well. The key differences I'm going to show you with the tuberculosis kind of phlebitis is really around the amount of hemorrhage, the amount of ischemia, and then potentially obviously neovascularization as well. This case doesn't have a lot of choroidal lesions, but in the choroidal lesions in a tuberculosis case are more likely to co-locate with the vascular changes. Here on this color picture, we see the hemorrhages, but when we do the fluorescein, we see this large area of ischemia, vasculitis, and obviously with a risk of future neovascularization as well. With the tuberculoma, there's large tuberculoma here. We can see that there's some apical ischemia from the compression from the actual tuberculoma itself, shown nicely on the fluorescein and later on the ICG as well. And we see this large area of leak as well. And this can be followed up to show improvement. So moving on to birdshot, there are obviously many signs from birdshot, both on ICG, colors, but the key things we look for on an FFA are the hot disc, profuse leakage, the leakage from the large vessels close to the nerve here, the perineural vessels, and then we can see some macular edema with some sparing of the fovea as well. With this other birdshot case later on with really profuse leakage, you can see the pseudo delay appearance where the retinal veins themselves actually appear darker because so much fluorescein has leaked into the retina. Distinguishing this from a Behçet's, this Behçet's, which can look relatively normal, has this extensive fern-like leakage. A key differentiation from the severe Behçet we just saw was the relative lack of involvement of the large vessels at the back of the eye there, and obviously the color and ICG findings will be different. Here. And just my final case here is a multiple sclerosis related intermediate uveitis, just to show you again the power of follow-up over time. So this patient has bilateral changes, quite severe, lots of vitritis. And in this case, the patient was treated with a fluocinolone acetonide injection in their left eye, and the fluorescein was repeated. And we're able to see the really clear improvement in the vascular leak, which then helped us to show to the patient that they should have their better eye, their right eye, treated with a similar treatment. So just to summarize, fluorescein angiography still has this vital role to play in diagnosis of posterior uveitis conditions. We use it alongside our other multimodal imaging to locate the pathology and assess the severity. It provides that baseline imaging and then helps us monitor response to treatment. It helps us check for complications. And as we've already discussed, the future, in the immediate future, involves linking it on OCT and ICG on the same machine, automated validation of our findings, and then hopefully AI interpretation of imaging to help us. So I'll finish there. And I'm going to move to the discussion. I'll be joined by Prof. Neri. Prof. Neri, if you want to join me now in,
sure.
In discussing these questions that you've put together.
Well, thank you very much for the beautiful collection of pictures. And actually, this is, very aligned to the benchmark of a top masterclass for this presentation. I can tell you that, fluorescein angiography is in my heart, because when I started as a resident, that was the very first thing that I might have done, because there were just a B-scan ultrasound and fluorescein angiography. ICGA was very brand new. And then now we have, multiple other kind of tools. So my simple question is that, we prepared the slide deck for the sake of being very didactic. So the first question is, in which clinical scenarios do you see fluorescein angiography essential? Because, back in the days was the only thing we might have done with B-scan ultrasound. And now where do you wish to allocate that in the current scenario when we have multiple options?
Yes, I think, it's useful for this talk to come after Marion's wonderful presentation, because as wonderful as the future is, and later on we talk about OCTA replacing fluorescein, I think there are still aspects that we can only see really at the moment with fluorescein, with leak, in particular retinal vascular leak, and then the ischemia, which you can see on OCTA, but is obviously highlighted very nicely on the fluorescein. So I think vasculitis, the severity of vasculitis, that kind of global examination of leakage in retinal vasculitis, really. So Behçet's and birdshot in particular.
So let's say that just to summarize, I mean, you recommend this in any kind of disease that might have a vascular component that is predominant to the clinical phenotype of the disease, particularly in Behçet disease or the diseases that you showed very well.
Yeah.
I don't want to go, through, all the questions that we prepared, but I wish to make a remark that is based on the fact that fluorescein angiography is the only kind of test that can detect the blood-retinal barrier impairment, which is not possible with any other thing. So I can agree with Marian about the fact that the blood-retinal barrier, or maybe the perivascular swelling, can be detected by fast OCT. But you cannot compare what you can get from fluorescein angiography. So what's your comment about the blood-retinal barrier impairment, particularly in diseases like the fern-like kind of phenotype, when you have, for example, Behçet disease or other diseases? Do you believe that this is one of the best qualities of this kind of technique that can address as a one of a kind in this specific kind of patterns?
I think absolutely. I think you yourself have published also on peripheral vascular leak and its significance. I think that's another thing, that the wide field nature of something like an Optos, unless you have the most up-to-date OCTA, is unlikely to be matched with the modern OCTA machines. And so I think that's another key aspect is how wide you can get with the Optos, which is freely available, I think, now for fluorescein angiography. So that's another key aspect, is how wide you can go.
Since time is very limited, I have a very rapid fire question and just for a quick answer. How do you believe, Will, or anybody here in the panel, are we far away to have an AI-driven potential, benefit in the real life? Because, research is certainly, very fascinating. It's great to have AI-driven decision-making, tools. But how do you believe that is far away to have a potential very pragmatic and, routine impact for the clinicians? How do you believe that we are far away to that?
Yes, I mean, one of the things we don't show in presentations is our real life use of the imaging software, where you literally put up the last visit and you put up this visit, fluorescein colors, and you use your own AI brain to then compare the two images and make decisions. And so I think AI may be able to highlight things that we might otherwise miss, but I still think the decision making will be done by the clinician.
That's absolutely remarkable.
Foreseeable future, yeah.
Is there anyone here, in the panel, or anyone that wants to highlight something about the beautiful presentation that Will delivered? No one? All right, so I thank William for the wonderful presentation. It's now my pleasure to introduce Ilaria, who's going to talk about decoding imaging findings in stromal choroiditis. Thank you.
Thank you.
Thank you, Dr. Neri. So we have the next presentation on stromal choroiditis by Ilaria. Professor Ilaria, she is the consultant ophthalmologist at Moorfields Eye Hospital. And the presentation will be discussed by Dr. Colin Chu, clinical academic ophthalmologist at University College London. Over to you, Ilaria.
Thank you, Annie. So I'm going to focus on primary stromal choroiditis, that are those conditions where the inflammatory process selectively targets the choroidal stroma. We have purely primary stromal choroiditis like BKH, and we have mixed stromal choroiditis that can be associated with retinal vasculitis like Behçet. So you all know that ICG is crucial for the assessment of the stromal choroiditis, but which are the clinical signs on ICG that can indicate the active stromal choroiditis? So first of all, we have the hypofluorescence dark dots. So the inflammatory foci appear as dark dots on the ICG. This is a case of Behçet. You can see we have the dots that are distributed over the whole fundus. And why is important to run your ICG until the late frame, until 30 minutes? Because in the late frame, basically you can see the choriocapillaries. So it's important to understand if the inflammatory foci occupy the full choroidal stroma, and they can basically create area of flow void also at the level of the choriocapillaries. And why this is important? Because of course, it will then affect also your outer retina. The second sign of active stromal choroiditis is indistinct choroidal vessel. So this is the case again of birdshot. You can see that in between the hyperfluorescence dots, you really can't see the choroidal vessel. So the choroidal vessel appear very fuzzy. They lost their normal aspect. And here it is. This is the picture post-treatment. So you can compare pre and post-treatment. And you see that post-treatment, you have a restoration of the normal aspect of the vessels. And this is another case, VKH, fuzziness of the choroidal vessel, pre and post-treatment. So this is basically indicates choroidal vasculitis that allow the extrusion of the ICG complex that is also at the origin of the sign number 3, which is diffuse late choroidal hyperfluorescence. These images are courtesy of Prof. Herbert and Ioannis from Lausanne, and you can compare pre and post-treatment. And post-treatment, you see the resolution of the diffuse hyperfluorescence. Last sign on ICG is disc hyperfluorescence. So normally the disc on ICG appear as black hyperfluorescence, as you can see in the left eye. In severe, really severe choroiditis, you can have hyperfluorescence of the optic disc, as you can see in the right eye. And this is another case, again from Lausanne, pre and post-treatment. You can basically focus on how change the appearance of the optic disc on the ICG. But how can what we have seen so far be translated into clinical practice? So let's focus on VKH. So why is important multimodal imaging and especially ICG in VKH? Because you need to diagnose early your disease, you need to monitor, and you need to assess for subclinical choroidal inflammation. So let's have a look at a few cases. So the first stage of VKH is what we call prodromal stage, where you have choroidal and meningeal inflammation. But what you have to know that in this case, subclinical choroidal inflammation is only visible on the ICG. So you have your hyperfluorescence dots because you are in a phase that precedes the acute phase that you all know. So the acute phase happens when the choroidal inflammation spreads to the surrounding tissues, meaning optic disc, retina, and you have, of course, the appearance of the subretinal fluid. So you have pooling and pinpoint leaking points on your FFA. You also have disc hyperfluorescence. So EDI-OCT is really important. You can see, of course, the exudative retinal detachment, but take a look here. You see the very, very diffuse thickening of the choroid. And this is another case. You see the choroid is basically thickened in proportion that can even be measured. And then, of course, you have your subretinal fluid and you can have choroidal fold. But why is important ICG? You see, in this case, a case that arrived to us in clinic, and at the beginning, when I saw this patient, I thought I was dealing with a choroidal effusion. But then I did the ICG, and the ICG showed hypofluorescence dark dots and also fuzziness of the choroidal vessel. So ICG allowed me here to diagnose as inflammatory something that at the beginning I thought was not inflammatory. And here is our patient post-treatment. You see it's a resolution of the hypofluorescence dots, of the fuzziness of the choroidal vessel after proper anti-inflammatory treatment. Also remember that VKH is bilateral but can be asymmetric. So this is a case that if you look only the OCT and the autofluorescence, you have subretinal fluid only in the left eye. So it can be only one eye involvement. But when you run your ICG, you see hypofluorescence dots even in the right eye. So remember that this is bilateral disease but can be asymmetric. So it's really, really important to monitor the patient with ICG even when the acute phase has passed and your patient is treated. Why? Because you want to avoid this. You want to avoid a chronic VKH with choroidal atrophy, so choroidal thinning, and then, of course, the typical the pigmentation finding like the sunset glow fundus and the Dullen-Fuchs nodules. You see, this is a patient who arrived to us on prednisolone for more than 6 months. And clinically, it looks all good. But if you look at the EDI or CT, you can see there is a choroidal thickening. And when you do your ICG, again, you understand that the disease is active. So it's really, really important to monitor with ICG for subclinical choroidal inflammation. If you don't have an ICG, EDI can help, but what is important of the EDI is that you have to monitor over time. So this is, you see from baseline to 1 year, you see the progressive reduction in the choroidal thickening. So it's always important basically to compare. So for the last few minutes, I would like to speak about birdshot retinochoroiditis. So what are the diagnostic criteria of birdshot? You have vitritis with retinal vasculitis, you have stromal choroiditis on ICGA, and you have to have a positivity of the A29. But what I would like you to focus your attention on is the point number 7, presence of right-shaped depigmented lesion. You see, they are strongly supportive of the diagnosis, but they are not required, and we will see very soon why. So this is a typical patient with birdshot that will basically walk in your clinic. So female, middle age, complaining of blurriness and floaters. You take a look at the fundus, you don't see really much, maybe just some vitreous cells, but then you do your FFA and ICG and you have vascular leakage and hypofluorescence dark dots. I would like now to focus your attention on the 3 possible scenarios that we have in birdshot. So scenario 1, you have the right-shaped typical birdshot lesion, and you have diffuse choroiditis with hypofluorescence dots on the ICG. So what is this is telling you? This is telling you that the disease has been active for a while because you have already the depigmentation finding on your fundus, and it's still active because you have active dots on the ICG. So this is different case, but same scenario, birdshot lesion and active lesion on the ICG. So what you have to do here, you treat your patient and you have scenario number 2. So you don't have the hypofluorescence dots anymore on the ICG because you treat your patient, the disease is not active anymore, but of course you still have your birdshot lesion because that are not reversible. So scenario 3 is the ideal scenario, meaning that you have a patient with no birdshot lesion and with active disease on the ICG. So you need to treat your patient early. You need to make your diagnosis early before the birdshot lesion appears, before this happens to the fundus of the patient. So this is why the birdshot lesions are not mandatory for the diagnosis, but are just supportive, because you need to treat the patient before this happens. So even in birdshot, monitor with the ICG is mandatory. You see, this is the first patient we see. After 6 months, she was on MMF 1 gram twice a day. We repeat FFA ICG, still active vasculitis, still active stromal choroiditis. So we add adalimumab, and then we managed to get inactive disease after 6 months of adalimumab. And again, like in BKH, if you don't have your ICG, you can use EDI as monitoring, comparing basically the choroidal thickening. And I just would like to conclude the presentation by answering a question that I've heard many times. So what is the clinical significance of these dots on the ICG? Do we really need to treat the dots? The answer is yes, because we want to avoid this. This is the patient who was seen by Professor Pavesio in clinic last week. You see, there is not much retinal vasculitis, so the patient was not really symptomatic until what? Until the choroidal inflammation became full thickness and there was outer retina involvement with autofluorescence changes. The patient becomes symptomatic with visual field defect, and this is when the patient presented to him. So this is what we want to avoid by treating the lesion. This is another case of ongoing untreated birdshot presented to us already with diffuse atrophic chorioretinal scarring. So this is the importance of the ICG, and this is the importance of treating your hypofluorescence dots. So I will stop here. Thank you for your attention, and I will pass it to Colin.
Thank you, Ilaria. Really wonderful and comprehensive presentation as always. I know there's a few questions appearing in the chat, which I'll leave some time for. And I also know in our discussions, we covered many points, so I'll just pull pull out a few that may be of interest. I think you've shown so elegantly, for example, of how we are all treating to imaging. And I think that is a concept we should all bear in mind. You know, certainly in the management of our birdshot patients, we are essentially treating to the ICG findings, which I think is a concept. You know, we know this with our OCT management of AMD, for example, but we are almost explicitly doing that. And I think that's really interesting. Another point is, obviously, at Moorfields, we're very lucky. We have a lot of access. We're probably doing, 10 ICG angiograms a day. And it really is the workhorse for the management of patients with stromal choroiditis. Because we've got a very international audience at IOIS, I wanted to just highlight the fact that people do have issues with access to ICG, either through cost, insurance systems, or just pure access. And so what can they do? And I think we've already heard some beautiful examples throughout the talk of using other modalities, such as OC and OCT angiography, for example, to look at the choroid. And I think Professor Neary's published some work as well on this. And then we also have looked at our birdshot patients recently and found that there are very few patients that are active on ICG that have a completely quiet fluorescein angiogram. So whilst most of them do, and you should always run both, that's our recommendation, I think the slight reassurance is that we've not almost seen no patients where the ICG is active and the fluorescein is completely quiet. It may just be something as subtle as a bit of disc hyperemia or a tiny bit of leak, but there is a way to do that. Also, as you mentioned, EDI OCT is also another indirect measure that most people can get. In our studies, a single measurement doesn't correlate well against the ICG angiogram, but longitudinally, as you showed, I think that is very useful. I guess the other thing, as you said, is what are these dark dots? And I think that's really interesting. You know, we always talk about biological and tissue surrogates, and so we often call these granulomas. But the answer is we're making these assumptions. We can't directly biopsy. And so we've been looking at some histology recently, and it's quite interesting. While some of them are granulomas in a range of inflammatory conditions, when you look at the histopathology, some may not be, and they may actually be what we call tertiary lymphoid follicles. You can get a whole range of other features that are doing that. And so I think it's very exciting with all the innovations like Marion showed as well, you know, where we can apply AI to our imaging and learn more and more. Just to remember what's actually going on at a biological level is still slightly elusive. So I'll pause there, and I think there are some questions in the chat. Yanis, Annie, do you have them?
Yes, actually, we're answering some questions. I mean, there is a question that I would like to share with you guys. How often do you do ICG on patients with a birdshot? I mean, here in Switzerland, we do at the beginning at 6 weeks in order to see how treatment is working, then every 3 months. But I don't know how are you managing this patient?
Yeah, I would say, of course, at the beginning, you do it a bit more frequently because you want to make sure that your treatment is working. And once the patient is stable on treatment, I would say that we do at least once a year then.
Ilaria, I think there's also a question, or did I see one about...
I think one of the common questions that comes up, yes, is the, you know, chronic VKH. ICG in chronic VKH and hypofluorescent dark dots. Do you treat? Do you not treat? If we can just have an answer in maybe 1 minute, and then we can go on to the next talk.
Yeah, so you always treat the hypofluorescent dots.
Go on, Ilaria, go on.
Yeah, so if you run a VKH, so you need to be careful because, of course, you will have some hyperfluorescence dots that might already represent scarring. And you see that they are appearing from the early phase until the late phase, and they are basically unchanged. Of course, you don't treat that because that is just scarring. But if you run your ICG, you will see that if it's active, you will have other hyperfluorescence dots that will come up. And of course, it will change during the phase of your ICG and are usually not so dark like the appearance of the dots that represent scar, are more like dull grayish. Of course, these represent active disease and you need to treat it.
So do you ever correlate the finding on imaging ICG or FA for case of birdshot like this to a functional measurement like visual field?
So we usually do EDT, electrodiagnostic tests, at least once a year in birdshot, just to make sure that the patient is also functionally stable.
What I'm trying to say, Elijah, is that do you see any true corresponding let's say when you see active lesion and ICG in the case of birdshot, do you then see a visual field, for example, a Goldman visual field that show a defect, and
So
then
the visual field effect is like the one of the last patient that I show is not correlated with the active hypofluorescence dot, is mainly correlated with the outer retina change on the autofluorescence. If the dots are basically full thickness and they already affected the outer retina, then we see, yes, changes in the visual field.
Great.
So I think we can move on, and it's a pleasure for me to call on stage Dr. Edmund Chui from UCLA in Los Angeles to present a focus on anterior segment imaging in uveitis, and Professor De La Torre, that is with us from Columbia, that is going to discuss and lead the discussion for this presentation. Please, Edmund, up to you.
Perfect. Thank you. Can you see my screen there?
Yes.
Okay, excellent. So thanks for the opportunity to share today regarding some anterior segment imaging in uveitis. So, our talks here tonight had focused mostly on the posterior segment. I'm going to bring it towards the front of the eye for a little bit to discuss some aspects of anterior segment imaging. We'll go over grading of anterior uveitis, some examples of slit lamp photography, and then go over various applications of anterior segment OCT imaging in uveitis as well too. Give me 1 second here. My slides are advancing. So, as we know, we use the SLEN nomenclature to grade anterior uveitis with many members of our audience, as well as our panelists that were previously on this committee as well too. Just for starting from basics, obviously we know that these grades are categorical, and we translate the number of cells that we see in a high power field into a categorical number. But using a slim exam can be somewhat subjective, and we want to find out a better way to potentially use a more objective way, which brings in the imaging aspect of the imaging anterior uveitis. So again, we can use slit lamp photography to obviously document cells. We can see in this photograph there's numerous amount of cells, as well as maybe 2 to 3 plus amount of flare in the anterior chamber. But when we want to think about how we can get a high quality reproducible image, we look towards using anterior segment OCT, because as we all know, using slit lamp photography can be sometimes challenging depending on the technician and the skill of the operator. So the first attempts to quantify anterior segment inflammation was using time domain anterior segment OCT, and this was actually back in 2009. Agarwal and colleagues were able to quantify these hyperreflective foci using time domain OCT here in these images here. Obviously, it shows only part of the anterior segment, and time domain OCT at that point in 2009 had a limited resolution. So fast forwarding a few years, our colleagues over at Cleveland Clinic had looked at the use of spectral domain OCT to further quantify cells, and they showed a publication nicely here, going from 1 to 2 to 3 and 4 plus cells, showing that there was a clear increase in anterior chamber inflammation. So moving forward, there are many publications that looked at anterior segment inflammation as well as the amount of cells in the anterior chamber, and I'll go over a couple of examples here as well. The use of spectral domain OCT is, it's a widely available platform, but there's also the availability of swept source anterior segment OCT as well too. And you can see here in this image of this patient that had about 3 plus anterior chamber cell. This is the same image that was obtained simultaneously in the clinic, showing that the spectral domain OCT shows a reasonable resolution of the anterior chamber, but swept source really shows the entire depth of the anterior chamber quite well here. And this is a patient that I saw in my clinic. We had started them, we saw them with a grade 4 anterior chamber cell flare up of HLA-B27, and then we started them on frequent topical steroids, and you can see as we go on to 1 week on topical steroids, it decreased to grade 2, and then subsequently when we tapered off the steroids, they're grade 0, and you can see the resolution of the anterior chamber foci here. We further quantified these anterior chamber cells in using a fully automated algorithm that we recently published. You can see the representative figure in here going from, again, 0 to grade 4+. This has also been demonstrated and performed by many of our other colleagues. Alessandro Inverness and others have looked at using the air relative aqueous intensity ratio to also quantify the amount of anterior chamber flare as well too, and compare this with laser flare photometry and finding a excellent correlation. So there's many different aspects of how we can use anterior segment OCT to quantify inflammation. One of the utilities of this is really looking at the potential for how we can apply it clinically, right? We don't want to just look at the number of cells. We want to be able to quantify the number and apply this in a clinical setting. So here is a study that's happening in the UK using it to screen for JIA-associated anterior uveitis. And again, a couple of other examples here of how we can use anterior segment OCT. This is a patient with a syphilitic iris nodule. We can see diffuse iris thickening here. We started this patient on penicillin and frequent topical steroids. You can see resolution of the iris thickness as well as some of the keratotic precipitates that have resolved as well too. And then other examples of how we can use anterior segment OCT also include looking at various other biomarkers. So iris thickness and iris smoothness have also been reported in patients with anterior uveitis. So these are other metrics that we can think about because these are not quite standardized metrics yet, but these are biomarkers because there's so many different aspects of the imaging that we can analyze with anterior segment images. And again, looking at the keratotic precipitates, there are studies that now that are quantifying the amount of KPs. This is another study from Francesco Picchi and colleagues. You can see that they created an algorithm that quantifies or displays the keratotic precipitates on the near infrared, and over time you can see that these keratotic precipitates decrease over time with treatment. So another potential application of anterior segment OCT, especially using the near infrared images. Another last quick aspect I want to talk about is the potential for us to image anterior vitreous cells. So, you know, the Sun criteria did not come to consensus on what we can grade anterior vitreous cells with. But the MUST trial came up with this definition similar to the anterior segment grading scheme that we use. If you use the swap source platforms for the anterior segment, you can actually push the device a little bit forward. You can image the retrolental space here. You can actually see this in the patient that we had put on oral prednisone, and then the hyperreflective deposits and cells here resolved over time. And again, our colleagues have also begun to look at some studies and quantifying the retrolental space here with the cells. I want to end on a couple slides here, just talking about the need for standardization and future directions, because, you know, imaging the anterior segment for uveitis is not something we do in clinical practice on day to day. This is more of a research aspect. There are many different studies that have been published looking at various different scanning patterns. So there's a clear need for standardization of how we image the anterior segment. Importantly, there is a recent publication from many collaborators here led by Dr. Salibo, proposing these nomenclatures for anterior segment OCT. You know, this group came up with terms of how we can identify these various structures on OCT based on the swap source images seen here. So this is looking at, of course, the cornea and the angle and iris structures, and we had also reported on various other aspects as well too, including the lens anatomy as well too. So I just want to end here. There's obviously multiple advantages to us using anterior segment OCT imaging for the evaluation of uveitis. This is all still in very much of a research territory since it's not really used on a clinical day-to-day basis, but we can subject these images to a lot of different post-acquisition analyses. Artificial intelligence is certainly on the way here for these images. One day we'll be able to have more of a quantification used in routine practice and perhaps maybe even clinical trials in the future. Thank you. And then we will have Dr. Delatorre assist us with our discussion here. He's going to pull up some slides and some summary.
Yes, thank you, Adnan, for an excellent and insightful presentation. To briefly summarize this session, I will highlight the key messages, and then we will move into a short discussion. Recent advances in anterior segment imaging have positioned anterior segment optical coherence tomography as a powerful tool for the objective assessment of inflammation in uveitis. Beyond traditional slit lamp IS-OCT enables no contact, high resolution visualization of the anterior chamber and allows quantitative detection of inflammatory cells as hyperreflective foci, and the transition for qualitative imaging to automated sweep sorts AC-OCT-based quantification represents a clinical step toward reproducible inflammatory biomarkers with strong correlation to sun grades and potential sensitivity to subclinical disease activity. These developments are particularly impactful in pediatric uveitis, where clinical examination is often limited. Collectively, this body of work supports the integration of AS-OCT-derived metrics into translational research and clinical trials, paving the way for standardized objective endpoints in anterior uveitis. And to conclude, I have few questions regarding key aspects of this work. From a translational perspective, what do you see, Edmond, as the main barriers to adopting OCT-based inflammation metrics as primary or secondary endpoints in clinical trials?
I think that's an excellent question for us. One of the main barriers is really the standardization of how we approach imaging and how we quantify the hyperreflective foci or the cells in the anterior chamber. We're still, as a field, really trying to figure out white blood cells versus pigments, trying to optimize the best acquisition protocol. Are we doing dense volume scans? Are we doing radial scans? We're trying to figure out kind of what the best modality or the best acquisition protocol is, and that has to be standardized really before we can head into clinical trials or even use this in routine practice. So there's still, a lot of groundwork to be done, I think.
Okay, thank you. And concerning technical and methodological challenges, in your experience, how do automated cells counts perform in differentiating true inflammatory cells from noise, pigment dispersion, or debris?
Yeah, that's also an excellent question. I think what's difficult is, a lot of the algorithms that we have developed or haven't published set somewhat of an arbitrary threshold in terms of detection of the hyperreflective foci. So, the lower the threshold, the more cells you may detect. So there's a little bit of work to be done in terms of optimizing that threshold. I think when we use artificial intelligence or deep learning, we really have to think about basically what the ground truth is first and how we can really determine what the dots are. Are we going to have someone figure out the ground truth by manually counting or annotating these anterior segment OCT scans? Or are we even going as far as to potentially performing an aspirate of the anterior, the aqueous, and figuring out what type of cell population that is? So there's still, I wish I could answer that question better in terms of how we can properly do it. There's still a lot of research to be done in terms of trying to differentiate between these different characteristics and phenotypes in the anterior chamber.
Okay, great. And with respect to clinical integration, have you observed cases in which AS-OCT detected inflammatory activity not apparent on slit lamp examination, and how should clinicians interpret these findings?
Yeah, so I think using OCT certainly can become more sensitive to detecting these foci in the anterior chamber over a slit lamp examination. It's still to be determined the clinical impact of if we see 5 hyperreflective foci or 10 or 15, like, is that going to correlate with a low-grade inflammation, or is that really just noise sometimes? And is there a threshold that we can call kind of a quiet anterior chamber? So we do see, long story short, we do see hyperreflective foci in eyes that are clinically quiet, but we should follow these eyes over time longitudinally to really determine the clinical impact and what the threshold would be of what we call inactive versus active.
Interesting. And now moving on the topic of pediatric uveitis, given the challenges of examining children, do you think ASOCT could eventually redefine disease monitoring standards for pediatric uveitis?
I certainly hope that's the case in the future, especially for screening for uveitis. Our colleagues in the UK and others around the world are trying to look at the utility of using OCT for screening for JIA, uveitis. Potentially, we have these devices in rheumatology clinics. Patients may not have to travel so far to see a pediatric ophthalmologist or uveitis specialist. And if they have flare-ups or other needs for monitoring, we could certainly potentially implement a telemedicine model. But that's really far down the road, because again, we have to address standardization and optimization of some of these algorithms before it can really be deployed. But that's something that we can hopefully look forward to in the next 5 years, maybe.
Okay, great. And finally, looking ahead to future directions, what would be the key elements of an ideal multicenter study aimed at validating ASOCT-based inflammatory biomarkers?
Yeah, I think getting some of the device manufacturers on board as well too, to help with some of the algorithm development, as well as standardizing kind of how they store their images. That's going to be one of the first steps to be able to even enable a multi-center study, because there's so many differences between the different devices. We all have to have the similar device or the same device really to perform a multi-center study. Swap source devices are fairly expensive. Spectral domain devices are more available, but have a different resolution and scanning speed. So again, it comes down to the standardization of the platforms and the algorithms. So we're still somewhat fairly far off from it.
Okay, thank you, Edmund, for your great presentation and discussion.
Thank you, and sorry about my video.
Thank you
I think
very much,
it wouldn't turn
everyone, to
on.
all the speakers. No problem. Thank you to all the speakers and discussants, and I'll just like to give it to Dr. Nguyen for the final word.
Well, certainly it's been absolutely wonderful for the last 75 minutes to have experts from truly different part of the world to join us for our first International Ocular Inflammation Society webinar here. As you can tell here, even after all this wonderful presentation, over 200 participants are still with us online, so there are many listeners right now. I certainly appreciate the expertise from the presenter and from the discussion. We certainly have learned a lot. And more importantly, we learned a lot from different aspects, different colleagues from different parts of the world. So therefore, we would be able to share the experience that we ourselves, our own institution, may not be doing, but we can learn some other across the globe. So certainly, thank you to Aniruddha and Waru for putting together this wonderful program. And this is only the first one of the series of 6 that we're planning, and we're looking forward to many more to come with this aspect. So thank you again. And Aniruddha, would you like to mention when is the next one would be yet for our next webinar?
Our next webinar is scheduled for 18th of April. And please, stay back for more information on this. We'll have it on the website, and we'll circulate it to all the participants very soon.
Yes, so thank you for that, Ani. And so the other aspect we want to mention is that all of these wonderful presentations will be kept right now open for many of us to look at, and then eventually they will be kept on the IOIS website for our member to view. So certainly if you miss a part of this, eventually as a member of the IOIS, you will be able to access them. Is that anything else? Anything else to mention from there?
That's all.
Great.
Thank you.
Thank you. So we'll wrap up that. Thank you, Anuradha. Thank you, IOIS, for leading this first webinar, and we look forward to seeing you in a few months with the next one.
Thank you,
Thank
everybody.
you, everyone. Good night, good day, wonderful day. Bye-bye. Thank you.
Bye-bye.
Bye-bye. Thank you. Bye-bye.
Bye.
I'll end the event.